Today on Translating Health, a Frontiers CTSI podcast, we have Dr. Ayo Olagoke from the University of Kansas Medical Center, Wichita campus joining us. So welcome, Ayo. We are so glad that you're here with us today. Why don't you start, let's start with just a little introduction and maybe you can tell us about your background and how you found yourself at KU Medical Center.
Yeah, thanks, Heather. So my name is Ayo. I'm an assistant professor at the Department of Population Health at the KUMC Medical Center, Wichita campus. Um, a lot of my work is focused on health communication, but I'll talk a little bit about my background and how I landed here because it's a convoluted journey. So after my master's, towards the end of I have a master's in public health, health promotion. But then towards the end of my master's program, we had my supervisor did a research I had my master's in Nigeria in the village, and then we wanted to disseminate our findings. So we brought people from the rural place to the city, and then my supervisor and the other researchers, they were disseminating the findings, but I could see confusion on the faces of the community members. So after the event, I was asking them because I was like, I'm like an usher by the door doing refreshment and all. So I was asking them, hey, what did you guys get out of what we discussed? And to my amazement, they were like, we honestly don't really understand. Like, we don't know what you actually like we can't really say this was what we could make out of it. So I was getting that repeatedly, which made me then think I think there's a disconnect between how we speak in science as researchers and how community members want to hear. So I started thinking of what are the ways that I can communicate health findings in a way that it makes sense to the lay audience, which is where I got into health dissemination and using arts and different ways that could make health information relatable, narrative health and all. So from there, I decided that I was going to go for my PhD, but before then, I wanted to test out something. So I started one of the first public health stage play group in the country. And then what we'll do is we would go and do stage play in rural communities and we'll partner. We started with sickle cell awareness. So we'll do stage play on genotype testing and why you should know your genotype. We'll take like publications and read, but then we'll translate it into stories. And then after that, we would partner with an organization that would actually do the genotype test because there are lots of misinformation around genotype testing, like a whole lot. So we will do a pre and post like knowledge, and then we'll ask them baseline, and then we'll do the stage play, and then they would be able to go test after watching the stage play, like, oh yeah, okay. And then they'll do the testing for free, and then we'll do a post test. Then we started having community members saying, hey, we want to be part of your stage play. We want to join you. So we started raising ambassadors who would promote health information using stories, and then we'll train them and say, hey, now go to your community. So I saw that was working, but then I wasn't sure what was making it work. So I thought, I think I need to go for my PhD to find out how do I replicate this success to the point where it's automated and I'm so sure that, like, how are we writing the stories that is making it work? Like, are there um ingredients that we should preserve? Are there frameworks? Are there, like, how do we guarantee that this will always work? So, which was why I had my PhD from UIC Chicago. And then I focused on health communication. From there, I had my postdoc at Washington University in St. Louis at the Health Communication Research Lab, which was like all health communication. And then I started learning how I could actually use technology to do this. And after then, I got certification from the New York Film Academy on storytelling, script writing. So that's why I said it's been like a convoluted journey. And I felt like telling that
Yeah.
story is the only way to kind of let you see how my journey has been. So now a lot of my work revolve around health communication to the lay population, disseminating health findings using narrative health or stories, and helping people using technology to create high quality stories that would talk about health information and also other technology-based solutions. But the whole goal is how can we make the lay population understand it? Like they don't
Yeah,
understand our p-values. So how can we make it
right.
easy? That's kind of like the core.
Yes, that's fantastic and such a noble cause to bring that information to everyone. That's
Mm,
obviously what we need to kind of move healthcare forward.
mm,
My background is in linguistics. That's my undergraduate, and then I got a doctorate from KU in language development. So I've always been really interested in how we use language to tell stories and how we use
mm,
language to convey information. So I'm really excited about what you're working on and learning even more about it.
mm.
Um, okay, so as you said, your research is on public health communication. So you've told us a little bit, but can you maybe tell us what exactly that means?
Mm. So health communication can mean so many things, but um, my way of seeing it is increasing the reach and the effectiveness of health information. Two things. We want to increase everything I do is how can we increase the reach, that's the spread, have more people hear it. And by reach, I mean this is where message tailoring comes in. This is where precision health communication comes in. We want people to be able to make informed decision that would make their health better for better health outcome. But we know that to make that type of decision, information is so important. If I hear that, like many of us have heard on the news and all, if I hear that taking the flu shot or taking this type of vaccine would harm me or would harm my child, then I won't want to take it, no matter
Right,
what you say, but
right.
because of what I have heard. So how do we convey accurate health information to people in a way that they would understand it? So increasing the reach. And by reach, I mean how the way you convey information to me might be different from how you would reach someone else. For some other people, you reach them by just giving them a brochure. Some other people, you reach them by, adding emojis or doing TikTok. So how do we increase the reach of health information? One of my desire is I don't always like it when my research work just gets cited, like, and that's the end. Like I'm always feeling like, especially because of the type of research that I do, I want to get it, beyond that. I want to increase
Right.
the reach. So those are the two main things for me, increasing the reach and the effectiveness. To make it more effective, we need to do quality work. That's why I
Mhm.
invest a whole lot in some of the projects, which I'll talk about later, we're doing now. We're doing 3D animation. And I was doing like a demo session for a collaborator recently, and he saw it and he said, "This is pixel quality." I'm like, that is what that is what we want to get. So it's like, did you guys do this animation? This is pixel quality. And so for us to increase the effectiveness, I've heard people say health information, like health videos are usually cheesy, like poor actors, like you would know this is for health, it's boring, it's dry. They just want to make it, they just go straight to the point, like don't text
Yeah,
and drive. You text and drive, you're gonna have a crash. Like, so don't text and drive. Like it's real. So for me, a lot of my research is how can we break that? How can we go into the things that people love already? How can we talk about cervical cancer using a reality show? Like how can we, these are things that people watch
yeah.
and they relax and they can watch over and over and they watch season films. How can we just sip in something about hydration, into a sport game? So um, that's kind of like how my own aspect of health communication is. People focus on different areas. There are colleagues, wonderful colleagues who do work around health communication theories, and that's their area. There are those who do message development and content evaluation. But the part that I focus on is more of increasing the reach and the effectiveness and making sure that people are able to make informed decision for better health outcome because they understand and they can access um, accurate health information.
That's wonderful. I like also what you brought up of kind of more of the big picture of how can we get some of these small but really important messages out on a much larger stage, right? So you said, just a hydration reminder during a sports game. What a great idea. So how are you approaching these? Are you doing like um almost like ad campaigns in different media? Like I guess what methodologies are you trying out or have you found effective?
Yeah, that's a great question because, like you said, the picture is big and we need to find specific ways. I would say that three major things that my project kind of center around, and these three things can then go into multiple. First of all, when I think about my career, I look at it from three major perspectives. I think of it as what population do I want to serve? Um, you know, so I know there are people who I've worked with and I work with who they work with older adults. Like that's the population of interest that they serve.
Hmm.
So you see them do vaccination among older adults, physical activity among older adults, cancer prevention, older adults, because that's the population that they've adopted. Because really it's hard for you to kind of just do this generic thing, because you want
Yeah.
to specialize as well. So for me, I had to figure out what population do I think the message that I'm bringing they need it the most, or would really really be of huge benefit. And it doesn't mean I don't work with others, but for me, this is like the primary. So what population do I want to focus on, and then what health topic do I want to focus on? I have colleagues who work on like maybe lung cancer prevention. So you see them do lung cancer prevention among African Americans, lung cancer prevention among, but that's like the core subject matter expertise that they build. And then number three, so what population, what health topic or subject matter do I want to focus on? And then number three, what toolkit do I want to use?
Hmm.
For me, my toolkit is technology-based health communication. That's
Okay.
the approach. That's the toolkit. For me, the population is underserved. So this mainly involve rural population and immigrant. Um, you see that the other side is kind of broad, but most of the times rural population, immigrant group. And then number three, which is the subject matter, the health topic, for me is accessibility, connecting people with available healthcare resources and services. So accessibility to healthcare resources. And these resources could be events, it could be informational resources, like, hey, this is what you should know. I said that to explain how I'm approaching this. So when I collaborate with people, many times it's either because we share population group, or because I'm working with a colleague from New York. She has access to an immigrant database wider than I do. So we are working with her on that, but then she doesn't do AI work. And she has been looking
Okay.
for how she could start leveraging AI for health communication. So I'm like, you have access to the population that I'm interested in. And then I have this toolkit that you are looking for, kind of like how, think of it in the entertainment industry, how you would have a popular musician who sings a different genre, then collaborate with a different one. So you have all the fan base from the two. And that's the way I see collaboration in research. You do this, I do this, we come together and then we do much more. So I kind of look
Hmm.
at all of those three areas. So I'm approaching this by first, one of the projects that we've been running since 2021 is the I Heard project. And this is what we do here, which I'll talk about later on, is the goal of I Heard is to build an infrastructure. I love building systems. What I told my colleague from New York, like, she has access to immigrant, um, but then she doesn't have a structure, like for like if you need it now and that system. So I'm like, we need to build a system, we need to build a database, we need to build and digitalize it and make this accessible for all. So what we're doing, I heard is an infrastructure. and the big question we're asking is, what health information are people hearing in their communities? That's the big question. And how is this shaping their health? So we've been running this since 2021. We have, I heard, in different states. And the goal is, what are people hearing? If we address it, and we've been able to, we could tell the life cycle of health information. We could tell you that this information will last for X number of weeks. We could tell
Interesting.
you what to prioritize. Sometimes the health department, or you read on the news, you're hearing different things. We're hearing this, we're hearing there's food recall, we're hearing this, but when you test it empirically, you might see that people are really not hearing those things, you know, and maybe there's a group that is hearing it more than the other group. So that helps us to design messages that are more tailored for that particular group. So I heard is a system, is an infrastructure, health communication infrastructure we're building in cities. We want to be able to share information intelligence so that Kansas can say, hey, Missouri is hearing this, and Missouri can say, Kansas, are you hearing this? Because it's spreading in Missouri. It might come to Kansas, maybe something around measles type of misinformation, which we've heard a lot of those type of things. So the I Heard project that's ongoing. We're looking forward to getting collaboration in Kansas. We've had I heard Omaha, I heard St. Louis, we've had in about 7 states, Colorado, Georgia, and one of my goal here is to find collaborators that would host I Heard here in Kansas, or even in Wichita. We can have like an I Heard Kansas to see what people are hearing and to see how that's shaping their health. The other way that I'm approaching this is through storytelling. So right now we are creating um, um, my research lab is going to be like, we've been working on the website and all. Hopefully we launch it by next month. But we're creating more and more stories. We just got a grant to create a video library for on pediatrics oncology in Uganda, and we're working with collaborators from Washington University. Our own lab is building all the stories, all the videos for the library,
Wow.
and we're addressing treatment abandonment. Now, in the past, you would not have been able to build. I mean, if you want to do a video in Uganda, you have to travel to Uganda to do it.
Right.
But right now, we're using AI to
Okay.
recreate the setting in Uganda from here, and we are creating characters that look like the people in Uganda. We did this also in Louisiana. We're contacted to create a tailored video on prostate cancer screening for African Americans using landmarks in Louisiana. So, like the streets and all of that, the
Yeah.
communities. And we did it from here without having to go there.
That's
So we'll
amazing.
yeah, so we're moving towards what I call precision health communication, where we can create a message for you, for your
Yeah.
community, and you would watch it and you will feel like this is a personalized message. We're also prototyping tools, AI tools that's going to make health information more accessible. One that we're really testing now is a tool that we have the beta version, like the prototype version. This tool would take people's characteristics. Let's say an example of one that we created. It could take up to 50 characteristics from an individual and then create personalized health information for them. So for example,
Interesting.
let's say I like Panera bread. I watch this type of show, and it could tell me, hey, get your flu shot. It's 5 minutes away from your Panera bread store, and like you can get it and also get your bread. And so we're taking all of those digital footprints, characteristics, or let's say I love emojis with my messages. I like it funny. So we're going to take a key message, which is like the generic, and then we're then creating different versions. And we can create 1,000 messages, different messages, still the same thing, but personalized for 1,000 people in less than 5 minutes
Oh
with
my
this tool.
goodness.
So everybody
Wow.
get what they like what appeals to them, and they enjoy reading the health information. You
Yeah.
get it in emoji, you get it with your favorite shopping place, you get it with your favorite show. And these are even characteristics that like they are not formal, it's not like based on my age, my race, or whatever, like we would usually do, but more on the things that make you you, the things like
Okay.
informal, conversation, because we are not always rational as humans. We have other sides. So we don't just want give me the formal information. And we've done a field test on some of these messages where we compare messages that we developed with the CDC formal secular
Yeah.
kind of message. And we saw that we did this on HPV vaccination for parents. And we saw that parents who received our own kind of message reported higher intention to vaccinate their children compared to those who received the secular CDC message. So what we are doing is what we call equitable messaging. We believe that there is no one size fit all, kind of message for everybody. Like different people would prefer that their message would have this. But traditionally, it's hard to create, unique message for everybody.
Right.
But then with technology, we can do that. And we're pushing for that. So we're pushing for precision health communication, and it's going to be a whole lot thing, because our goal is we want to give you precision health communication, not just from the text perspective, but let's even say you like 3D animation. And even for 3D animation, let's even say you like anime 3D animation. Like, can we get it to granular to that level where everybody just begin to receive health information in a way that they would like to get it?
Yeah.
And let's see how effective that will be. So that's like um what we've been doing and working on.
That's amazing. How does, so with the personalized messaging, you said you can generate up to 1,000 messages in 5 minutes.
Mhm.
Um, is that messages as in like a text message, a video that might pop up on TikTok or something? Like what's the, if I'm looking
Yeah,
at my phone or I don't know, looking
yeah,
at my phone is the
yeah.
most realistic thing,
Hmm.
right?
Yeah.
How is that information going to get to me?
So currently we are in the testing phase where we have what we call anchor message. So let's say we take a message from the CDC, like the standardized message. So that's what we then make into different versions for different people. So we're guarantee of accuracy, we're guarantee of all of that.
Hmm.
And then so currently in the testing phase, we've not started giving it to specific individuals, except for our research participants that would just test it. But ultimately, how we see this implemented, which I think is what you're getting into, is we're thinking of things like newsletters. So, for example, there are newsletter platforms that allow you to create for each recipient to get unique messages.
Wow.
That feature, it's not always used. People use it for things like, and I don't know if you've seen newsletters that says "Dear Hater,"
Yeah.
like they see your name, and everybody gets their own name because there's a field that lets you do that.
Mhm.
So our goal is that we want to start saying, "How about we work with newsletter outlets, that share health information, maybe from your hospital, where sometimes I get from my hospital where they say, hey, it's flu season, Ayo, you should think of getting a flu shot or something like
Right.
that. So can we start to work with EMR or healthcare facilities, that send these routine messages, and start making sure that people get different types of messages based on their preferences. And we want to see the open rate. Are people more likely to read engagement rate with emails that are hyper precision personalized versus
Yeah.
people who receive just the generic? So it's in stages, but the phase that we're in now is we're just testing out the tool, demonstrate effectiveness, and see how can we start to scale this. And if we see from this first phase that people who are receiving this personalized are reporting high intention to take up the behavior, or even if they are not, and we learn from it and we revamp it and we see the questions they're having, and then we're able to increase effectiveness at that level, then we can go to a health facility and say, hey, if you're trying to do this, or we can even work with the health department to say, instead of sending out this message, and then you can, try this out and let's see how this make people take better decision. The ultimate goal would be for us to also see how we can, I mean, this is like a far long-term thing. How
Hmm.
about on your social media page, you're able to, select how you would like to see your messages. We have a tool. One of the tools that we're looking at is this was developed for a team on mental health, and you're able to say, I don't want to see anything that would raise like you can do that setting,
Yeah.
like
Yep.
filter out, block out any news that's gonna kind of trigger me and make me.
Right.
So we did that like a plugin that you would install on your browser, and it kind of just work on that to filter the type of news you receive. So thinking of that type of approach, for health information as well, like how you click on something on your browser and it translates your messages from English to Spanish or so, and you can be seeing a Spanish screen. So can we do that type of personalization also for health information where I see my health information in a particular way? So those are like far
Yeah.
long-term thing. Um,
Wow.
yeah.
That's, oh, just the potential and the capacity is
Mm,
fascinating.
yeah.
So with health misinformation, we know that's on social media. Um, is do you think is the goal to prevent health misinformation from being disseminated, or is it to more effectively disseminate the correct information? Like, how
Mm,
do we combat the
yeah.
misinformation?
That's a great question because it's a hot debate in the field of health communication. We talk about debunking versus pre-bunking. So debunking is like what you first said, the misinformation is out. We want to debunk it. We want to correct.
Hmm.
We want to provide corrective, accurate health information. Pre-bunking, on the other hand, which lots of research is showing that is even more effective, is we want to build health knowledge before the misinformation comes. So we want to build health knowledge such that before people hear those things, we anticipate what they might hear.
Hmm.
Like sometimes you hear that a kind of regulation is going to be coming out. You could tell, which is what we're doing with I heard. We want to be able to predict what type of misinformation is likely to come out due to this. And then we want to mitigate it even ahead of time, create stuff for it. So what we are doing with this precision health communication is we believe that, like I said, increasing the reach and the effectiveness. When the health information is enriched, is effective, and the reach is getting to the right people, maybe people that are more likely to have limited health literacy, or which is why we work with underserved, or people that are less likely to comprehend it if we present in a
Hmm.
big way, because these are areas where misinformation comes. Misinformation comes many times when there is limited knowledge on a particular topic, when there is not about, like you could see during COVID, so much
Right.
uncertainty. This person said five
Yeah.
feet, this says 3 feet.
Yeah.
So those are the cracks through which, for example, misinformation is lower when some things are, it's like if it's snowing and you come tell me, do you know it's not snowing? I'll be like, no, it's snowing. Like I
Right.
see it. You can't really confuse me when it comes to that. But if you can confuse me by saying, do you know the temperature is 30 degree when it's actually 35 degree? Because I don't know. There's multiple steps for me to confirm that. So
Right.
if we can make health information as clear as day, explain it in simple ways, um, which is one of the reasons why in research there's, like I shared that story, that disconnect where um there is publication, science say this, even something as little as 3 out of 10 people, or something as little as correlation versus causation,
Hmm.
like maybe there's a research paper and the conclusion is that 20% of those who took the vaccine also said they had tummy ache. Now, that can cause a whole lot of trouble for someone who doesn't know the difference between
Right.
correlation and causation. Because, and you've probably heard those type of things where someone says, oh, And we heard that those who took the vaccine are also hospitalized. So the vaccine caused the
Right.
hospitalization.
Right. When it's,
Um,
oh, they're actually hospitalized for something
yeah.
else. Yeah.
So all of those, if we do not communicate in a way that people understand,
Yeah.
then we are creating rooms and avenue for misinformation to grow. So this approach that we're using, which is us trying to make sure health information is accessible in a way that you will understand it, and also building trust through that way, I would say it could serve both ways. It could serve the pre-bunking, where we're building health knowledge in a fun way, and people are learning without feeling like I need to go learn about this and
Right.
read a brochure, because the mental demand for when you're reading things like brochure is quite high. You have to follow logically, and it has its
Mhm.
place. You need to follow the argument. But I don't know if it's ever happened to you sometimes that you're just singing a song and you're like, when did I even learn this song? Like, I didn't
Right.
sit down to write the lyrics and learn it. I was just driving, they were playing it on the radio, and I was just humming it, and you're just like, I'm singing this song. So we are thinking of how can we um come through the I'll say maybe the informal, like edu entertainment kind of thing, where you're learning without actively switching off to say, I
Right.
want to go learn this. And that way, we're addressing misinformation through pre-bunking and also debunking um, through that way.
Yeah. That that's a great explanation and great examples. Thank you.
Yeah.
So with kind of all the technology work and the AI work that you do, is your team, it sounds like your team is probably fairly multidisciplinary, interdisciplinary, whatever term you
Mm,
prefer.
mm.
Um, but what other roles are there on your team or the folks that you work with?
Yeah. So like you rightly said, we're pretty multidisciplinary, and I like it that way.
Yeah.
A lot of our collaborators, like we have a wide range from researchers to community leaders. There's a project we're doing currently um in a county here in Kansas, and we're working with the legal team, like law enforcement agents, because we're dealing with gender-based violence, and
Okay.
we're doing videos on deep fake and sexual exploitation through technology in this rural community. And we're trying to help stakeholders who are doing this, including the Attorney General office. We're working with the Justice Department, and we're coming together to say how can we do this. So it's pretty diverse, but at the end of the day, there's a lot of my type of research is applied research. There's a
Mhm.
lot of application that comes up from it, in the sense that it we are doing projects that would be taken up by the community and would drive change. Like our goal for this particular one is to build a library, a video library we've done preliminary studies where stakeholders have listed the things they would like to learn, and how there's so much limited knowledge on sexual exploitation, technology-based sexual exploitation, especially among teenagers. So we're seeing more and more of teens reporting mental health issues because of people sharing their deep fakes, videos about them, not knowing how to safeguard themselves online with their photos, especially with AI tools, and you just upload your videos and then your images to different tools, and they come up with things, and before you know it, you see someone else using your image to create a video that is not really you, and it's not something you would like to identify with. So we're helping people to know their rights on of first, we're letting them know how to protect yourself online, what type of
Mhm.
information you should share and you should not share. So we're doing that digital literacy thing. But also, what step can you take as a teenager or as parents? And even we're working with organizations that deal with gender-based violence and sexual exploitation in the rural community. How do we start to build that? So some of these projects, uh, they involve multimedia, like Riley says, because it's very multidimensional. We're hoping to do a screening, like where we'll do a screening of these short movies, and then we'll bring stakeholders, and then hopefully we can get policy out of it. So the type of collaboration and the opportunities that exist, we're always looking for subject matter experts. We're
Hmm.
working on multiple things. Um, I'm working with a colleague. Shout out to Dr. Chen. She's gonna listen to this. I'll make her listen to it. But she's at the KU Lawrence campus. Excellent colleague. She's a professor in communication. And
Oh,
then we created a chatbot together, an AI-powered chatbot at our own lab, created it on menopause communication. And she's submitting it for us to go present at DC. We actually trained that menopause with information from the Office on Women's Health on menopause. So it's like we took their website and then we put it into a chatbot. And then we tested the chatbot with reviewers. We have physicians who reviewed it for accuracy and all of that, and is scoring really high score. So she's gonna present that at the office. So the Office on Women's Health is doing a conference in DC where they're
oh,
asking people to come talk about advancement on menopause. So I just sent it to
perfect.
her like this is like the perfect time for us to go.
Yeah.
So he's like, yeah, she's so we're putting that together. So we're working with subject matter expert because there is a in the field of AI, like there is a lot of it's a two-edged sword. I mean,
Yep.
AI can be used for good or bad. We've seen lots of negative report. We are very aware of that, and we so any tool we are building, we're evaluating. So we're actively seeking collaboration on subject matter experts. For example, I'm not an expert in breastfeeding. I'm working with a colleague, Dr. Jacobson Lisette, shout out
Hmm.
to her.
Yep.
And we're also building that AI chatbot on breastfeeding for breastfeeding moms. And we're trying to make it multilingual so that they could have chatbot where, when you're breastfeeding. And we also tested that. We tested that with 3 lactation experts.
Okay.
So that's the type of collaboration. That's not my subject area.
Yep.
So we got 3 lactation experts and they're testing and evaluating our own in-house chatbot versus generic because we tested with ChatGPT Copilot to see how is ours performing. So I'm always seeking collaboration. It's almost like I recently I met 2 cardiologists and I'm like, hey, let's do something on AI and you guys will review for me and kind of evaluate it. We're building rubrics on to evaluate AI output and to make recommendations. So my collaboration has kind of cut across. Once you're doing a resource, which is why I talked about the 3 areas for me, my population, underserved. If you're working something underserved, then I'm thinking, how can we leverage AI to make this more increase the reach and effectiveness of the information you're providing? If you're working something on resource, navigation for people, connecting people with services, then I'm like, how can we use AI to help you amplify that and increase the reach and effectiveness? So those are the kind of collaboration that I always jump at. And it's really exciting. We're working with someone from KSU, and we're doing, stuff like physical activity for his lab.
Hmm.
So that's like, um, but underneath all of this, you will see the population. Like for me, when I reach out to people for collaboration, it has to be that there is something you do, one of those 3, that
Yeah.
kind of align. So we're open to collaboration, all of that line. Happy to connect.
That's great. That's great to hear. I wanted to ask is just kind of with that skepticism some people have with AI,
Mhm.
how do you approach that? Or do you have any recommendations or suggestions for folks on how they can, discern what's truthful, what's not truthful, things like
Yeah.
that?
Yeah, that's a fantastic question. So there are 2 extremes. There are people who are anti-AI, like everything AI is bad, everything AI is bad. There is the other extreme of people who are like, yeah, it's the best, it's the best, it's the best things. Um, I try to stay in the middle, cautious
Hmm.
optimism and cautious engagement, critical engagement, like as you're delving into it. I don't think either of the extreme is right. I feel like AI is a tool that can mess up, that can be for good or for bad, depending on
Yeah.
who's handling it and how skillful you are. It's like saying, "Oh, cars crash. I'm gonna keep trekking. I'm not gonna use a car." But a car is just a tool, and you have to learn how you drive it and how it
Yeah. How
works.
to use it.
And
Yep.
yeah, and then I like to use the automobile analogy because if you look at cars, for example, there is legislation and regulation at different level. Now, at the level of the car makers, like the car companies, there are regulations, like there are best practices you need to meet. That's why sometimes they'll recall a car. That has nothing to do with the driver, but from the creation point,
Mhm.
there are things you have to do. And I've been seeing a lot of conversations like that around AI, where people are talking about, the tech companies, how do we build a safe one? The data you're using to train, how do we make it representative? At that level, that upstream conversation is really important. But I also think less of what we've been seeing is the downstream conversation. In the analogy, that would be for the drivers. What regulations we create for
Right.
the drivers? Now, when we make these regulations, how do we then educate drivers? Because even though there is a law that says don't drink and drive, that still doesn't mean someone won't do that. So just looking at that also, even though a car is a great tool, we're still building regulations at the upstream, at the manufacturer level, at the driver level, at the road condition level. We're also
Hmm.
making sure the environment is motorable. We're creating speed breaks and traffic lights and all of that. So all of these levels have to also be replicated for us to have optimum AI safety. There has to be AI literacy for AI users. We need more of that. We need more people to be aware. I mean, just like you were talking about how people use the internet, how do you know what to put, what not to put, sensitive information? We need it at that level. We need people
Yeah.
to learn to use it and feel comfortable. We also need governance. We need people that would regulate the space, the road condition, in that regard. So some of the things that we've been doing, we cannot target all of this. We can't do upstream and all. Couple of things, a few things. We are working with my colleague, Dr. Z from Fort Hayes University and Tatiana from KHI. We are working on a policy recommendation, a policy document. Tatiana will be presenting for us in DC. She would be meeting with stakeholders and senators and all of that. But the goal is for us to present a policy memo. So Dr. Z is leading it from Fort Hayes, and Tatiana and I are working. Um, we are doing this so that we would be able to create policies. So from the policy
Hmm.
perspective, we're doing that. That's going to probably address things around governance and integration into workplace, especially we're using the rural context, healthcare. So policy level, we're trying to do that. That's not my strongest point for doing it. But other ways that we are addressing the safety, especially in the creative space of what we do, we're making sure that we do full disclosure, especially when we're dealing with participants or we're producing videos. Almost all of our videos, you will see and we're going to do a research on this, on how do you make what is good disclosure.
Hmm.
So but one of the things we do now is at the start of our video, you see, we tell you what AI did and we tell you what humans did. We don't just say this
Okay.
video was produced with AI. That's not full disclosure. So we tell you the images and the visuals of this video were created with AI. However, the content was reviewed by public health experts who did XYZ. So that's
Okay.
the kind of disclosure we give. And one of the things we want to test now, we want to do a video where we'll want to test what type of disclosure is good. Before video disclosure, all through video disclosure like a watermark, or after video disclosure. So we want to test that, just have 3 experimental groups and we
Yeah.
disclose before all through like a watermark, you see it all through, and then we want to do post video disclosure. So we want to be able to make recommendations and say, so we're doing um absolute disclosure. We're also making sure that we put a face, like the source is clear. um in almost all of our videos, we always end it by quoting like real findings. want to say something like, do you know studies have shown this, scientific findings, and which is like the backbone for what we just showed you.
Hmm.
So we want to make sure there is a source. We want to say something. Where is this message coming from? Because, like I said, misinformation comes anywhere there's a gap. Anywhere there's a gap in
Yeah.
knowledge, people can fill it up with, well, we don't know who created it. Maybe it was created by this. So anytime you leave a gap for people in
Yeah.
communication, you leave them to fill up the gap, the space. So we are trying to make sure there is a face, which is one of the reasons we started working on our lab, so that we can say this was produced by this lab, like we
Yeah.
said it, put it there, let people see it, or this was sponsored by the office of this, or this information was drawn from the cities and here's the link to it. So like let people have face, let there be a
Yeah.
source, make it clear. The other practical thing we're doing now, we're moving more towards animation versus realistic images. So in the videos that we create, like with AI, you could do realistic image. We've done that. I have my AI avatar that speaks Spanish. I don't speak Spanish, but I have like an AI twin that looks exactly like me that speaks Spanish and educates in Spanish, even though I don't. But the videos we're creating now, we're beginning to do more of animation versus realistic videos because we've seen pushback on people like you create a realistic person, but then that person is not real, it's AI. So we figure that anecdotal evidence shows that people spend more time worrying. They don't even focus on the contents. They're like, this looks like AI, this not AI, this looks like AI, this not AI, the hand is fine, it's the alpha. And they get distracted from the real message.
Yeah.
So we're going all animation, and we have a study in the pipeline to do the same video, realistic, the same video animation, and see how people receive it. So that's the kind of research that we're also doing. Like we're testing these processes. We want to be able to recommend what AI tool is doing the best and what type of tool is producing. And we want to be able to give evidence-based recommendations on how best to approach this. Um, so those are some ways that we're addressing the skepticism around it.
Mhm.
Those are not gonna solve all of the problems, but that upstream, downstream thing, just like the car analogy, is all needed as we learn. And we also do what we learn in the open. So I started a LinkedIn group that's called AI in Health Communication. And we've had like massive explosion in less than 3 months, because we started in November. We have about 51 members currently. These are people that are just joining. So we do currently, I'm sharing my weekly learning. I'm taking a course from the Stanford School of Engineering on AI integration, workplace, and product development. So I'm sharing my weekly learning on that. And we have professionals from different parts, like researchers that I look up to. We have some of them there like, hey, we want to come learn from here. So we do what we call open learning, like we share what we're learning from,
Yeah.
you know and we're also having some conferences coming up where we'll be doing breakout session, showing people how to use this tool, make them feel more comfortable, because anytime there is a black box, there is a mystery, misinformation comes in. And so we want to demystify AI use, especially in health communication, and help more people feel comfortable. Because when you know the truth, it's easier for you to spot the fake. They do say
Yeah.
that the way they train bankers to recognize counterfeit money is that they train them to recognize the original. They teach them all about the original. That because when you know so much, you know the weight of the original. Like they don't teach
Yeah.
them by showing them lots of counterfeit, because there will always be more counterfeit and they can't teach them on everything. So they do say that they train them more on recognizing the original, because the more they know the original, anytime they see a counterfeit, they will know. So the same way, we're doing this workshop and breakout session to teach people on how best to use this tool and how this tool works. And the more comfortable you are seeing it more and more, you're able to decipher, no, this is not best practice. So yeah, we're doing action lab, demonstration, demo lab. demo sessions, breakout sessions, and also hosting these conversations, which I'm glad you gladly gave us audience to talk about. But it's gonna require collaborative work to get it done.
Yeah. If someone wanted to know where you were giving presentations or leading breakout groups, is there somewhere they can find that information? Or should they just shoot you an email?
Yeah, I think just shoot me an email.
Okay.
Our research lab is going to be up by next month. I just need to do the
Okay.
final review and then we'll have our events all listed. But please, yeah,
Perfect.
feel free to reach
Yeah.
out, email me. I'm always happy to chat on all of this.
The Kansas Science Communication Initiative at K-State.
No, I haven't. I
Okay. I
haven't.
might put you in touch with them because I'm sure they would love to learn more about
Oh, that would be great. Yeah. I think Denver is the only person I have met for now.
her
Hello?
named Jacqueline Wegley, who I've been working with a bit on science communication programming. Um, and I think, yeah, that would be a great
Yeah,
connection for each of you to make. So,
absolutely. That would be great. Um, I'll be happy to make that connection.
okay.
Thank
Well, I
you.
won't take any more of your time. I think we went over, and I really appreciate um, your time and learning all about this.
Thank you
And
for your time. Thank you. I mean, I just reached out to you guys. Thanks, Kelly, at the last minute.
you've been listening to another episode of Translating Health, a Frontiers CTSI podcast, hosted by Dr. Heather Fielding Gebhardt and produced by Kelly Hale.